Hello friends, welcome to my new video, Transtubular Potassium Gradient or the ttkg. Before going to my video, please subscribe, like, share and don't forget to press the bell button for more updates. Transtubular Potassium Gradient. This is very unique to potassium. This is an index reflecting the conservation of potassium in the cortical collecting ducts of the kidney. It is very useful in diagnosing cases of hyperkalemia or hypokalemia. It helps you to interpret the urine potassium by adjusting it for the water reabsorption in renal medulla. So what is the formula of ttkg? You calculate urine potassium divided by blood potassium. You divided the whole by the urine osmolality divided by the plasma osmolality. Or in other words, ttkg is equal to urine potassium into serum osmolality divided by serum osmolality into urine osmolality. I told you ttkg is very unique to potassium. You don't say TT sodium gradient or urea gradient. Why? Because here and all we use fractional excretion. We don't use fractional excretion in potassium commonly because in fractional excretion of potassium it does not consider the water effect in the potassium excretion. We know water reabsorption takes place in the distal nephron as well. And whenever you do a urine potassium concentration, you don't actually assess the effect of water. It is not an accurate index evaluating the distal potassium secretion because the effect of water is not taken into account on the urine potassium concentration. So, by calculating the ttkg, we adjust it for the degree of medullary water reabsorption, which increases the urine potassium concentration as more water is absorbed. And we don't actually calculate the serum aldosterone or urine aldosterone level as it's not readily available. And the aldosterone levels may not reflect the mineralocorticoid bioactivity in patients with aldosterone resistance. We usually, even though there are a lot of tests like 24-hour urine potassium, urine creatinine, random urine potassium, fractional excretion of potassium, and by doing, for example, 24-hour potassium excretion and all, it will take time. And nowadays we don't do this, and it does not indicate the pathophysiology as well. It's a very weak test. So most commonly we do a test called as ttkg, and you should know the basics and how do you do the test. In order to do the ttkg, there are two conditions that should be met simultaneously. One, your urine sodium should be more than 25. So why you want a urine sodium more than 25? Because of the optimum function of the potassium, because of the optimum function of the collecting duct, because it depends upon the sodium delivery. So that sodium delivery is not a limiting factor for the potassium excretion. So that's why you need an optimum sodium delivery. So you should have a urinary sodium more than 25. Another prerequisite is that you should have a urine osmolality which is equal or greater than the plasma osmolality. And here you need vasopressin action which is optimal for the potassium secretion in the distal cortical nephron. So when you have these two conditions that is met simultaneously, you can calculate the ttkg. And what does this ttkg convey you? Actually, the ttkg will make you understand whether the patient is having the ability to handle the potassium properly, either in a hyperkalemia condition or a hypokalemia condition. So when you have a hyperkalemia, how do the kidneys handle your potassium? The kidney will try to secrete potassium and your ttkg is high normally. And in hypokalemia, the potassium is conserved by the kidney and the kidney ttkg will be low. This is the normal functioning of the kidney. So a hyperkalemia, remember, will help you to understand whether you are dealing with a renal problem or a non-renal problem. You expect a ttkg to be high in hyperkalemia and you assume that it is not a renal problem, it's a non-renal problem. If the hyperkalemia you are getting a ttkg less, remember the kidney is unable to handle that properly. So there is something with the renal system. In hypokalemia, if the potassium ttkg is very high, it is a renal problem because you need to conserve it. So ttkg should be very low. But instead, due to the problem with the renal system, that we will come into detail, the ttkg is very high. So what does this indicate? It all actually indicates the aldosterone activity. The ratio of tubular to venous potassium indicates the level of aldosterone activity. In the presence of hyperkalemia, the ratio should be more than 10. That means the aldosterone is functioning properly. In the presence of hypokalemia, the ratio should be less than 4. That means the aldosterone is functioning properly. So whenever you have some abnormality, you will get problem with the decrease or increase in the value of the ttkg, and you understand is it a renal or a non-renal one. So again, the expected ttkg is more than 10 in hyperkalemia. Whenever you get a low ttkg, remember you are dealing with a hypoaldosteronism or a renal tubule defect. And in hyperkalemia, you expect a ttkg less than 2. But when you get a value higher than that, what does it indicate? The renal system is not functioning properly. That means you are having a hyperaldosteronism. So coming into detail, we will see how you are going to approach first in case of hyperkalemia. I am not going into detailed evaluation of the hyperkalemia. I am just trying to make you understand about the value ttkg and hyperkalemia. How do you assess by the values? So in hyperkalemia, whenever you get a hyperkalemia, you go for a ttkg. So what do you normally get expect in hyperkalemia? You expect the kidney to excrete more potassium. So your ttkg should be high, isn't it? So when the ttkg is high, you are dealing with a non-renal cause. So what are the non-renal cause? It could be either due to a reduced extracellular volume, or it could be due to a decreased tubular flow as in advanced kidney failure. So when the ttkg is less, that means there is some problem with the aldosterone activity. So if you have a hyperkalemia and your ttkg is less than 6, then this means the collecting tubule is not responding appropriately to hyperkalemia and the potassium secretion is impaired. Actually, ttkg, as I already told, it's a measurement of aldosterone activity indirectly. So whenever you get a ttkg less than 6, it can either be due to a decreased aldosterone level, aldosterone resistance, or a problem in other parts of the tubule, that is the distal convoluted tubules. So if you get a ttkg less than 6, initially, next step is to do a stimulatory test. You give fludrocortisone, you wait for 4 hours and repeat the ttkg. If it is more than 6, it is an aldosterone deficiency. If it is less than 6, either it could be due to an aldosterone resistance or a distal convoluted tube defect. So what about hypokalemia? Likewise, in hypokalemia, you expect the ttkg to be less than 4. If the ttkg is more than 6, then it means there is a renal problem. Either it can be due to an hyperaldosteronism, or it can be due to a segmental problem in the other than the cortical ducts. So this is all about the TKG. Hope you like my video. Thank you. Thank you for your patient listening.